Okay, so welcome to today's Grand Round. My name's Chris Louie. I'm the consultant for the REMU team here. This is my first time doing the Grand Round, so be gentle with me. Anyway, we've got an exciting roundup of cases here today, starting with the REMU team, starting with Dr. Matt Wheeler, who was the registrar with me on the team at the time. We're doing a flying solo. Am I safe to fly, Doctor?
So I've been banished from the REMU team. That's why the ex-REMU is there, and I'm now on the relief roster, but that's okay. This is what we're sort of going to go through. Supposedly, all great presentations have to have tell you what we're going to do during them. So we've got the case. We're going to talk about the physiological effects of flying, the evidence that's surrounding safety to fly. We'll follow off with some recommendations, and there's some questions that I've put through in the middle there. And if anyone does have any questions at the end, by all means put your hand up, interrupt, and we'll see how we go. So our case is a 72-year-old Māori gentleman who presented to hospital here. He normally lives in Brisbane, and he says on interview that he is normally fit and well. He's been over in New Zealand for a tangi. He unfortunately lost one of his children and has been here for the last 7 days or so. He tells us that he's been having trouble with shortness of breath and swelling of his legs for the past 2 weeks. It's been slowly increasing and progressive, and he now can no longer walk more than 20 metres. Throughout this entire time, he says that he describes no chest pain of any type, and we tried very hard to get this history out of him. Of note is that he was on digoxin, despite the fact that he says he's got no past medical problems, and he was on an angiotensin receptor blocker from Australia of some description. Examination of this gentleman showed that he had an increased JVP, he had decreased air entry basally, and he had bipedal edema. Bloods that we did show that he had a troponin of 560 that was going down on repeat, and a BNP was done at the time. Although he clinically was in heart failure, the purpose of this was not to prove that he was in heart failure, but it was so that we could get a handheld echo done by the cardiologist on call at the time. We didn't really want a formal echo because he wasn't going to be here for very much longer, and was from the moment of admission was already saying, when can I go home? But it did show, as suspected, that he had a genuinely decreased LV systolic function with regional wall motion abnormalities. So we diagnosed him with a non-STEMI, heart failure secondary to one. He was treated appropriately, but him and his family were already saying, when is he safe to return home? So our first question is, when is he safe to return home? And I'm not going to expect an answer from you now, but I'd like everyone to, at least at the beginning, to lock in what their thoughts are around the length of time for safety. And of course, this could go on. If you think that 6 weeks is a little bit too short even, by all means, lock in your mind a longer period of time if that's what you think. Question 2 is, this is the beginning of the physiology section now, is what is the percentage of O2 at sea level? And I've deliberately put what does it matter in C because as anyone studying for exams knows, that C, or the longest answer, is always the correct answer. So I've deliberately debunked your theory there. Who's for A? Who's for B? Who's for C? Who's for D? Yeah, 21%. And this gives us an equivalent of alveolar O2 of about 13.7 kilopascals. So therefore, we've now talked about sea level, but this is about flying. So which one is correct with regards to airplane travel? Is it A, the cabin pressure is actually sea level, the percentage of equivalent O2 percentage in air is 15%, and that is equivalent of 9.18 kilopascals? Is it 2,500? Is it 8,000 metres above sea level? Or and these are equivalent. So but they're just sort of to give you an idea from the previous question. So who's for A? Who's for B? Who's for C? Who's for D? And who's for E? So the majority are correct, it is actually B. And so cabin pressure is typically, the planes are flying higher than this, but they sort of have a midway point where they pressurize to about 2,000, just under 2,500 meters above sea level. This drops the O2 percentage in the air to 15% from sort of the appropriate, from sort of normal, which is 21. And it drops the alveolar O2 from 13 to about 9.18. And other things of note is that this also causes gas expansion in any trapped body cavities by about 1/3. Here's just a lovely diagram that sort of shows that. And the reason why I've sort of used alveolar PaO2 at the moment is because obviously your lungs, I think, would change how much your arterial O2 is. So I didn't think that that was necessarily important, but there obviously is the dissociation curve of sort of where you are at ambient temperature as you go down there. And so this was a study in 1998 looking at, it wasn't actually regarding air travel at all, it was actually regarding just sort of high altitude climbers and things like that. And so they were going up to 5,800. So we're sort of in the middle here, sort of coming down there, and so that's sort of appropriate. So there's your 13 and there's your sort of 9.18 around there. With regards to the compensation of what the body does, once it's subjected to these, this decrease in oxygen saturation, this increase in pressure, is you've got hypobaric hypoxia, and this causes a certain number of different compensatory mechanisms. The first is sort of in the lungs, and that you get an immediate increase in the minute ventilation or the tidal ventilation. So they start breathing a little bit heavier. That you get from the hypoxic vasoconstriction, you get a bit of arterial constriction, which can cause worsening, or it does cause an increase in your pulmonary arterial blood pressure, and you get and you find that the hyperventilation decreases your arterial CO2, which causes a respiratory alkalosis, which can cause a left shift in the O2 dissociation curve. So you actually get more oxygen delivery to your tissues. And as you go on further at that sort of level, you get a reversal of that curve back to the right. And just for interest's sake, that's because of a buildup of 2,3-diphosphoglycerate. The heart increases its cardiac output as well. So you've got an increasing heart rate. Interestingly, your maximal heart rate actually drops, and this is due to some sort of autonomic response, and that limits the amount of myocardial consumption. Hypoxia is a vasodilator, but the increase in heart rate balances the vasodilation, and so you actually you find that your blood pressure doesn't drop even though your heart rate does go up. The kidneys also show that there's hypoxic diuresis, and so and this sort of, at that high level, this is sort of also aims to bring up your hematocrit and improve your overall oxygen delivery to the tissues. So this is from that same 1998 paper, and it shows over the minutes to days to actually up to, interestingly, they've decided that they can figure out what the compensatory effects are up to 30,000 years in the future. And but you see that there's even minutes into the flight, you've got an increase in your heart rate and then an increase in your hyperventilation. And so you can imagine that someone on a 24-hour flight is starting to get a CO2 ventilatory response and an increase in your hemoglobin concentration from even at that point. Although I haven't put it up here, the cardiac output numbers that they've given in the British Cardiovascular Society suggest that at room air, your cardiac output is around 7 litres per minute, and that at an oxygen saturation of 80.5%, you're actually getting 8.4 litres per minute. So you've got to sort of get an increase, and that was statistically significant with a p-value of less than 0.05. So 1.4 litres per minute increase in your cardiac output. So a somewhat significant rise in your cardiac output for some people. So those are sort of the physiological effects of flying, and now we sort of turn through to the evidence and the studies. And in all honesty, there's an absence of good research with regards to this. I've got a couple of studies here, and in fact, even finally, we'll talk about the British Cardiovascular Society guidelines, and they even state that there's an absence of good research into sort of effects of flying and sort of the risks of flying. So this was a 2002 study, and they looked at people 2 weeks post an uncomplicated MI. So essentially no post-MI angina, no arrhythmia, no congestive heart failure. They were looking at the rates of ischemia, the need for supplemental O2, and the need of whether or not these people needed a medical escort. And of course this was done by a medical escort company, because I think they were trying to determine the level of intervention that they needed to provide with regards to people who were flying. Their numbers were very small. They only ended up with 15 people. Essentially, they randomized them to a group with oxygen, a group without oxygen, and everyone got a Holter monitoring tracing done throughout the flight, and that was the way that they were going to tell whether there was true ischemia or not, was whether there was ST depression during the flight. So their primary endpoint was ischemia as seen on the Holter, and their secondary endpoints were chest pain, complaints of shortness of breath, detection of bigeminy or trigeminy, and saturations of 90%. Although in the initial bit of the study they did say that everyone to be included would be able to walk up one flight of stairs without stopping and without getting chest pain, in the results they actually found that only 77% of people were able to do that. So you can see that, I mean, even there were some people who couldn't even walk up one single flight of stairs who were in this study, and they found that, I mean, small numbers, but there was only one person who developed asymptomatic ST depression lasting a total of 5 minutes, and he was in the non-O2 group, and as I said, he was asymptomatic through the entire thing. 2 people had chest pain, 5 people had transiently low O2, and those were obviously in the non-oxygen group. And basically, this with the sort of, as we were talking about, the bigeminy and trigeminy, in the 2 groups they had equal numbers of minor endpoints in both groups, and it was not statistically significant that one asymptomatic ST depression. So then we turn to a 2006 study that's in the Heart Journal, and they were looking out of Britain. They were looking at safety at aeromedical repatriation, and they took 213 people. I mean, this is it's now starting to get a little bit larger, and they were looking at people. So we've determined essentially that waiting 2 weeks is, you're relatively safe to fly. There were pretty minor endpoints there. And so they were looking at whether it was safe to actually go under 14 days or whether you needed to go over 14 days. And in the under 14 group, 70% of those people who were under 14 days flew at less than 10 days, and 10% of those flew at less than 7 days. Group B, interestingly, flew for longer, quite considerably longer, than Group A did. And they found that only the people in Group A got 3 of them got angina. It was noted again that no one was allowed to get low saturations, and only 10.7% of Group A got low saturations versus Group B. But I think that's also probably, they did mention that it was to be noted that Group B obviously had a much longer flight time, so it was therefore more likely to get transiently low saturations. And their conclusion essentially is unclear whether the supplemental oxygen confers any medical benefit to patients in flight. So the British Cardiovascular Society actually put out a set of recommendations just 2 years ago, and in it they actually give no grades or levels of evidence, and that's basically because they say there isn't enough evidence for us to even provide any level of evidence. But the House of Lords decreed that that the British Cardiovascular Society and the British Thoracic Society needed to provide guidance around flying, because obviously people are getting older and are flying with more medical conditions, and so that they wanted some sort of guidance around when people could fly. And this is what they came up with post-MI. If you were aged less than 65, it was your first event, successful reperfusion, and ejection fraction of greater than 45%, you could fly after 3 days. So that's hopefully shocking to some people, because it certainly shocked me. It's interesting that they call them very low risk and high risk. It's not low, medium and high, but these are word for word what they've got in here. If you had an ejection fraction of 40%, no signs of heart failure, no evidence of inducible ischemia or arrhythmia. They gave them 10 days. And they took this, you might say, well, 45% to 40% is a pretty minimal difference. And where the evidence comes from this is a study that was looking at early discharge of patients with MIs. So this had nothing to do with, the evidence for this is nothing to do with flying. It's all about people who have early discharges. And what they were looking at Killip class on admission, they were looking at TIMI score, they were looking at age, as sort of probably the three major ones. And they made up a score, and they found that people with low scores had, after 2 days, their sort of risk of any event plateaued. With this sort of medium risk group, they found that after 10 days their risk plateaued, and for the high risk, it was obviously the risk was significantly higher. And then when they echoed all these people, that's where they came up with this sort of ejection fraction. They found that this score was directly correlated. And actually, this is statistically significant here between these two numbers, and that's why they've set 40 and 45% as two significant differences. Interestingly here, they've got with signs and symptoms of heart failure, and this still doesn't provide a great deal of guidance. If you've got an ejection fraction, you've had an MI, you've got an ejection fraction of less than 40%, but still no signs of heart failure, you sort of fall into the sort of grey zone in between saying, oh, I should defer the test, defer the flight, or whether they should be allowed to really fly. But certainly this was a lot shorter than what I thought it would. And then we start talking about heart failure, because heart failure was one of the major ones. And their basis of they said that anyone with an acute episode of heart failure should wait for 6 weeks. So all of a sudden we've gone from talking about MIs being discharged in days, or being able to fly after days of having an MI, and all of a sudden to talking for people with you've had an MI, but you've got a bit of heart failure. All of a sudden now you've gone from potential of 3 days being able to fly to now you're having to wait for 6 weeks. And once again, it's all based around the rates of complications, and they say that the rates, the highest in a few weeks after the infarction, but stabilises after 45 days, which is essentially the 6 weeks. And so that's where they're getting all of their sort of recommendations. So with regards to heart failure, and they do even say in it that even if you change one medicine, you still have to wait for 6 weeks after. So the recommendation is no change in medicine, stable heart failure for 6 weeks, you're allowed to fly. And so 6 weeks to me actually still does feel like quite a considerable length of time. In New Zealand basically follows the British Cardiovascular Society. They've got a guidance to doctors document, but they basically say that anyone with angina, anyone with previous cardiovascular disease, and anyone with heart failure, basically if you can walk 50 metres or walk up one flight of stairs without chest pain or shortness of breath, so there's that one flight of stairs again, they're allowed to travel. However, once again, they've got this 6-week mark for the acute heart failure. And I think we'll find that as more research goes into heart failure, maybe that number will get shorter, maybe that number will get longer, as we've sort of seen in the progression of time with acute MIs. But definitely, this is sort of the decision around Air New Zealand. There's a letter that got sent to Jeff Garrett last year, and this is a quote from out of that article, well, from out of that letter. I should mention that whilst the attending discharging doctor may determine that the patient is fit to be discharged from hospital, the ultimate determination around the patient's fitness for air travel rests solely with the Air New Zealand medical team. And they are present and contactable between 6 a.m. to 11 p.m. 7 days a week. So they must provide pretty good service in order to do that. Probably, one might say, better than the hospital, but I won't go there. I'm sure you appreciate the risks involved, especially for international travel, because at the end of the day, we can, and what prompted this letter is there was a raft of patients last year who were turning up with a discharge summary, were going to check into their flights and were saying, here's my discharge summary, I'm ready to fly. And the ground staff were like, yeah, And they say that it creates quite a considerable amount of stress for not really the ground staff, but for the patient as well, as he or she is whisked off to the medical services to get a quick check over and before flying. The funny thing is about all of these, and even back into the 90s, all of these fitness to fly documents, as they say, arrive in plenty of time, don't rush, don't stress. So they're all very much about not being stressed with flying, and they feel that one of the major components for exacerbation of heart problems is actually the flying themselves. So we go back to question 1, and when is he safe to fly home? And actually the answer is, it's really not for us to decide. So a great outcome of an amazing talk, I know. But then, while I was actually doing a little bit of reading, I found this 1991. I know it's a bit old, but it was the FAA Civil Aviation were looking at the rates of usage of a medical kit on board a plane, and what percentage of medical emergencies do you think were in 1991, albeit, were attended by a travelling physician? Who has A, 5%? Who has B, 15%? Who has C, 35%? Who has D, 55%? Who has E, 85%? The answer is 85% were attended. So our patients are probably pretty well looked after up in the air, to tell you the truth. And I think this probably goes to say that a lot of them don't need a medical escort per se, because there's a high chance that they're going to have one up there anyway. And so that's pretty much it, really. A pretty underwhelming decision from an amazing talk. But if anyone does have any questions, I'm welcome to take them. Well, Chris is welcome to take them now. But there's my email if you want any of the studies, any of the British Cardiovascular Society stuff or anything like that. I'm more than happy to answer and email any stuff to you.